Our next speaker, Manjunath Pai, is an electrophysiologist from the Minneapolis Heart Institute. Manju Pai is working at Allina Health Minneapolis Heart Institute, and he has an interest in a broad variety of cardiac rhythm disorders, including atrial fibrillation, ventricular tachycardia. He performs a wide range of procedures to help manage and treat these arrhythmias, including cardiac ablations and management of cardiac devices like pacemakers and defibrillators. Dr. Pai performed his internal medicine and chief residency training at Boston University and performed his cardiology and electrophysiology training at the Cleveland Clinic. Dr. Pai has been with Allina Health MHI since 2017, and he'll be joining us online today. Dr. Pai.
Hello, everyone. My name is Manju Pai. I am an electrophysiologist at Minneapolis Heart Institute. I'm a cardiologist that deals with abnormal heart rhythms. So we deal with heart rhythms that go too slow or too fast. We do procedures like heart ablations, pacemakers, defibrillators. Thank you for letting me speak today. I'm going to be talking about common abnormal heart rhythms or arrhythmias seen after aortic or heart surgery. Just a slide to say that I have no relevant disclosures or potential conflicts of interest. So a few objectives today. We're going to review how the electrical system of the heart works, and then review some of the most common issues or complications we see with the electrical system after surgery, and then discuss potential treatments when we do see these issues. Just as a background, let's review some basic topics in regards to the electrical system. So the heart is really just a muscle that pumps blood. And our heart is powered by electricity. So just like a building or a house has electrical wiring, our hearts also have electrical wiring. So we typically have a spark starting at the top right portion of the heart, and the electricity flows down all of these little wires and goes down to the bottom of the heart. And as the electricity goes down, the heart in response pumps or contracts and shoots out blood to your body through the aorta. So just like we can have fraying of the wires in houses and buildings, our hearts can also occasionally have fraying or short circuiting, and that can lead to occasional fast heart rhythms. So on the left, we see the normal electrical system, but on the right, there's disorganized firing, which can lead to abnormal or fast heart rhythms. Or we can also have slow heart rhythms. So in this cartoon, there's a red mark showing that there was disturbance in that electrical wiring, which can potentially lead to slow or abnormal heart rhythms. There can be a variety of symptoms for either fast heart rhythms or slow heart rhythms. Typically with fast heart rhythms, we can see palpitations, or you can feel like your heart is fluttering or like a fish jumping around. You can feel tired or fatigued, lightheaded, dizzy. Sometimes it can lead to chest discomfort, trouble breathing, or just feeling overall poor and sweating, malaise. With slow heart rhythms, you can also feel tired, fatigued, lightheaded, dizzy. Sometimes in extreme cases, you can even pass out or what we call syncopes. These types of heart rhythms can occur in anyone, including young people with otherwise healthy hearts. But as we get older and we age, we can develop risk factors which do increase the risk for some of these different types of heart rhythms. So high blood pressure, uncontrolled sleep apnea, heart blockages, weak hearts, history of smoking or COPD, diabetes, prior heart surgery can all increase the risk of developing these arrhythmias. I think an important question is, are these arrhythmias dangerous? In general, the answer is no. Many of the rhythms that we see, especially after surgery, are not dangerous. They're not life-threatening. They may make you feel crummy, and some fast heart rhythms, if left untreated, the heart can get tired and weak and lead to heart failure over time. One heart rhythm in particular, called atrial fibrillation or atrial flutter, can increase the risk for blood clots or stroke. And some slow heart rhythms can make you feel really bad and sometimes need a pacemaker, but in general, they're not acutely dangerous or life-threatening. There are a rare minority of arrhythmias which can lead to acute or sudden death, or what we call a cardiac arrest. But these are the minority. They're typically seen in people who have very weak hearts. And these types of rhythms are very rare after heart surgery. So these are not typically what we're talking about. So how do we diagnose these abnormal heart rhythms? But the best method in the hospital is cardiac monitor, what we call telemetry. We're typically using these for all people who undergo open heart surgery for a few days until they're discharged from the hospital. And it's very easy to see on these whether you're in a regular rhythm or whether there's some disturbance in the rhythm or the heart rate. Typically, it's diagnosed before someone leaves the hospital after heart surgery, but sometimes it can occur in a delayed fashion, and there's various ways to diagnose these. Sometimes we have outpatient monitors. The one on the left is kind of a older style where you have multiple stickers or leads, as well as a device or two. There's been easier monitors to wear recently where there's just one type of patch that you can wear, and you can wear these anywhere from a day up to about 30 days, depending on how often the symptoms are occurring. Our wearable technology is also getting much better. We have different types of watches which can do a good job of monitoring the heart rate, sometimes trying to detect atrial fibrillation. For example, the Apple Watch, the Fitbit devices. There's also hardware that can be used with your phone. This is a very popular one called Cardia, which has little leads where you put your fingers on, and it gives a very nice tracing of what your heart rhythm is like at the moment. So what does all of this have to do with the aortic surgery? Slow and fast heart rhythms can develop after surgery anywhere, depending on the type of surgery and risk factors, from anywhere from about 5 to 60% of the time. Atrial fibrillation is the most common fast heart rhythm, and we'll spend some time talking about that. And we can also see slow heart rhythms, or what we call heart block, which is an injury to the electrical wiring. And there's two common medical terms that we use. If there's partial injury to the conduction system, it's often called a left bundle branch block, and complete injury is complete heart block. And we'll review both of these today as well. So some words about atrial fibrillation. First of all, as a background, it's the most common abnormal heart rhythm in adults, and the prevalence increases as we age. Once we reach about 60 years of age, an estimated 4% of the population is thought to have atrial fibrillation. It's thought to affect approximately 40 million people worldwide. It can be associated with a number of things, including fairly debilitating symptoms, increased risk for blood clots or stroke. In some cases, it can increase the risk of a weak heart or heart failure, which can sometimes lead to death. Going back to this cartoon I showed earlier, atrial fibrillation is due to chaotic electrical firing. So instead of on the left, you have this single source of electrical firing in the top right corner. What's happening in those top chambers is there's potentially hundreds of areas which can short circuit or spark, and the heart can catch on and fibrillate. In aortic surgery, the chance of atrial fibrillation occurring is probably about a third of the time. You can have various numbers, like I wrote here, from 15 to 60%, but I think about 1/3 of the time is a good rule. The majority of these cases occur while someone's still in the hospital before discharge, so usually by postoperative day 2 or 3. Now, luckily, most of these episodes are transient. About 2/3 of the time, the atrial fibrillation will resolve on its own, sometimes within a couple of days, but sometimes it does take 2 or 3 months to resolve. Are there risk factors for having atrial fibrillation after surgery? As we talked about, there are some risk factors going into surgery, increasing age, if you've had a prior history of abnormal heart rhythms, if one of the valves, specifically the mitral valve, is leaky or stenotic, if we have bigger hearts, if we've had prior heart surgery, if we have COPD or diabetes, if our functional status or exercise capacity isn't great. And if we use a lot of alcohol, that can increase the risk of having AFib. And there are some risk factors in terms of the surgery. So if it's a longer surgical procedure, if we have difficulty recovering after surgery, if we have a bad pneumonia or an infection, we're in the hospital longer, those can all increase the risk of developing AFib. This is the general treatment plan for atrial fibrillation. So there's three real pillars that we address when someone has atrial fibrillation. The first pillar is decreasing the risk of forming blood clots or having a stroke, for which blood thinners or anticoagulation is used. B, improving symptoms, so treating the heart rate, trying to stabilize the heart rhythm. And C, modifying risk factors, so making sure the blood pressure is controlled, making sure the blood sugar is controlled, making sure the sleep apnea is controlled, etc. So in the short-term management of atrial fibrillation, the first goal is to control the symptoms, control the heart rates, and there's various medications that can either lower the heart rate or even stabilize the rhythm back into a regular rhythm. Beta blockers are a common medication. Common beta blockers include metoprolol, atenolol, Coreg, or carvedilol. Sometimes we use stronger medications called sotalol or amiodarone to keep the heart in a regular rhythm. There are some situations where even with medications, the heart can be in atrial fibrillation, and we do a procedure called the cardioversion, which is a procedure that takes a minute or two. We put someone to sleep, put some stickers on the chest, and it shocks the heart back into a regular rhythm. Goal number 2 is to reduce the risk of forming blood clots or a stroke, and this is done with the use of blood thinners. Common medications that you may have heard about include Coumadin or warfarin, Eliquis, Xarelto. They all do the same thing in slightly different ways, but they're all fairly similar. Like I said, atrial fibrillation after surgery is usually temporary. It can sometimes resolve within a few days. Sometimes it can take a little longer, 2 or 3 months. But about 2/3 of the time, it does self-resolve. But there are times, about a third of the cases, where atrial fibrillation can continue after that 2 to 3 month window. And sometimes in those cases, we continue the blood thinners, we continue the medications. A little outside the scope of this talk, but for some people who continue to have AFib, sometimes we do a procedure called an ablation. It's not a surgery, but we put IVs into the groin area. We put tools up into the heart, kind of like an angiogram, and we cauterize or burn areas of the heart where atrial fibrillation may come from. And it's a good tool. It's not perfect, but it's a very good tool. Changing gears a little bit. Sometimes after surgery, we can see a disruption or damage to the wiring, which we call heart block. So again, in this cartoon, you see an impulse start in the top right corner of the heart, but there's some damage as you move down the electrical wiring, which can slow the electrical conduction, slow the heart rates. This is another cartoon where some layers of the heart have been taken away. So you can see the aorta here is that big red tube. There's a couple of valves. There's the aortic valve right below the aorta. And you can see in blue the electrical wiring. So we can't see this with our own eyes. It's in the tissue somewhere. And during surgery at times, especially if there's a replacement of the aortic valve or there's surgery very close to the base of the aorta here, that wire can get disrupted. The risk of this is somewhere between about 1 to 15% after cardiac surgery, probably closer to 5 to 6% in the majority of cases. It's typically seen immediately. So within, right after coming from the operating room, or within 1 to 2 days. It's very, very rare to see it delayed after someone leaves the hospital. Some occurrences are transient, meaning they resolve within a day or two. But if they persist after a few days, we typically have to use a device called a pacemaker to improve the heart rates, and I'll talk more about that in just a few slides. So this is another cartoon showing different types of heart block we can have. And like I said, there's two words that we use, complete heart block versus something called a left bundle branch block. So you see here in this cartoon that there's the main electrical wire, and then it bifurcates into a right-sided branch and a left-sided branch. And you can see a prosthetic aortic valve here. And so in this cartoon on the left, the prosthetic valve has caused damage along that main electrical wire. And so it disrupts everything below it. And this leads to what we call complete heart block, where the heart rates get very slow. In the cartoon on the right, that aortic valve is just a little lower, where instead of hitting the main electrical wire, it hits only that left-sided wire. And what this does is it doesn't always reduce the heart rates. It can sometimes slow the wiring, but in certain cases, when someone has a left bundle branch block, it may not affect the heart rates, and people may not need a pacemaker. So there's a lot of variables, but not everyone with a left bundle branch block necessarily requires a pacemaker, whereas in complete heart block, a pacemaker is required. So what is a pacemaker? It's a small medical device that treats low heart rates. Importantly, it does not treat fast heart rates. It does not treat irregular heart rates. It does not treat atrial fibrillation. It can make it easier to treat rhythms like atrial fibrillation because it makes medications easier to use. But what it does is treat low heart rates. It is also not the same thing as a defibrillator. A defibrillator is used to treat cardiac arrest in people with weak hearts. So it is not a defibrillator. It's about the size of a face of a watch. And what it does is increases the heart rates. It makes sure that the resting heart rate is always above 50 to 60 beats per minute. And it provides augmentation or rate response. So all of us have different heart rates depending on what we're doing. We may have a basal heart rate when we're sleeping, but that increases slightly as we stir and wake up. It increases even more as we walk or we do more laborious activity. And so these pacemakers have what are called accelerometers. They know when we're moving around, kind of just like our cell phone when we're moving it, and it increases your heart rate as you do activities throughout the day. It also serves as a constant monitor. So it records everything about your heart rhythm. It records if you're having any abnormal heart rhythms like atrial fibrillation. It records how often the pacemaker is working, what your heart rates are like throughout the day. And we can check it. So this is someone having their pacemaker checked in our pacemaker clinic. And there's a little wand that sits on top of where the pacemaker is. And we have a little computer screen where we can pull all the information about the device, see what the heart rhythms are like, what the heart rates are like. And it provides us a lot of useful information. The pacemaker implantation itself is what's called a minor surgical procedure. It's nothing like an open heart surgery. Usually takes about 30 to 60 minutes. It's done under moderate sedation. And for people getting this procedure done electively, they can often leave later that day versus first thing the next morning. And what we do is we make a small incision, about an inch, inch and a half underneath the collarbone here. And we're just going through the skin, and the device sits under the skin. And then through a needle, we put some wires down into the vein, down into the heart, and then we sew everything up. So it's all underneath the skin. Typically, it's a very minimal recovery period. Like I said, you can often leave within the same day or the next day. Take it a little easy on that arm, but otherwise you can get back to your life fairly soon after. It's a low-risk procedure. The risk of some kind of complication at the time of the procedure is very low, probably in the 1% range. And the risk of long-term complications are fairly low as well. Keep in mind that these devices are human-made technology. Imagine if you had a car for 20 years, things can happen to it. Components can stop working. There could be product recalls. And the same thing can happen with pacemakers. Sometimes if there's a severe bloodstream infection, it can spread to the device, making it more difficult to treat. Sometimes the devices have to come out, get replaced. Those are all low risk. They're not zero, but they're low risk. There is some maintenance involved. We usually check the device every few months or so, usually about 2 to 4 times per year. It doesn't always have to happen in person. We can do it remotely as well. And so there's a box that comes with a device that sits under your bed, and it communicates with us at regular intervals. So you don't always have to come in. And we have people who stay in, for example, Florida for the winter. They bring that box with them, and they get the device checked remotely without having to be seen in person. The battery typically lasts, depending on the type of device, anywhere from about 8 to 15 years. When it comes time to just having a couple of months left on the battery, that's the only time you have to come back to the operating room. And it's a fairly quick procedure where we open up the incision and change out the battery without having to change out the wires. At the end of the day, the goal of a pacemaker is that you get back to your life. You hopefully forget that it's there. You get back to things that you enjoy, like traveling, playing sports, exercising. There have been misconceptions based upon pacemakers decades ago, but you can use them around cell phones and microwaves. They're compatible with MRIs and CT scans. So again, the goal is that you get back to your life. So to summarize, one, arrhythmias are very common, and we can see arrhythmias about one-third of the time after aortic surgery. Atrial fibrillation is the most common arrhythmia after surgery, and luckily about 2/3 of the time it resolves within a few months. However, during that time, sometimes we need to use short-term medications, medications to lower the heart rate, or even blood thinners. Two, heart block can sometimes be a complication of surgery, about 5% of the time or so. If it's not transient, if it persists after a few days, a pacemaker is required. But again, a goal of the pacemaker is to get you back to your life, um, and not have any issues with that. So that's the end of my talk. Thank you very much for having me at this wonderful conference. And please let me know if you have any questions. Thank you.